Wish you all a very good evening. My talk is on genetic landscape of urological cancers. And I wish all of you, I extend my best wishes to you and to me also, because more than the timer is that last bell, which is very frightening, the tone of that. And I would like to avoid that part. So uh, let me go to the topic. Urological cancers have been poster boys for chemical carcinogenesis as well as for hormone dysregulation. But with newer technologies and advancement and generalizability of these techniques, we know that there are a lot of molecular events which are associated with urological cancers. Now, this talk is little different from the other talks because there are multiple sites in urological cancers and there is no time. So let's start with prostate cancer. Here, I'm going to discuss localized cancer and metastatic cancer because the molecular features are little different from one another. So based on whole exome sequencing data, TCGA classified prostate cancer, which is localized. First, I'm going to deal with localized prostate cancer. So that into 7 molecular subtypes. And there are fusions and mutations which were identified, and these are E26 transformation specific ETS family of gene fusions. So ERK, ETV1, ETV4, FLY1, and mutations are in SPOP, FOXA1, and IDH1 genes. And SPOP is speckle type pox virus protein gene. And in addition, there are remaining non-clusterable group of prostate cancer molecular events. And so coming to fusions, as I've already said, it's E26 transformation specific or erythroblast transformation specific ETS transcription factors family. And in this category, TMPRSS2 ERK fusion is the overall most frequent molecular alteration and is found in almost 40 to 50% of prostate cancers. Coming to mutations, now I must state here that fusions and mutations in localized prostate cancer are mutually exclusive, and SPOP mutant tumors are associated with deletion of chromatin remodeling gene, deletion of chromosomes 6q, 2q, and they correlate with higher pre-op PSA levels, but better metastasis-free survival because they respond to the treatment. FOXA1 mutations associated with early PSA recurrence post-prostatectomy, and IDH1 mutations make up 1% of the tumors, and they actually possess greatest levels of methylation and accordingly greatest amount of gene suppression, and they usually have early age of diagnosis. And so all the fusions and mutations are also seen in metastatic setting except IDH1 mutation. Now, this is the diagram which actually summarizes most of the molecular events in prostate cancer. And here I have also included information about metastatic prostate cancer. So upper part of this cartoon talks about fusions and mutations, which I've already stated. And the lower part, if you see, there is on the left side, localized prostate cancer. And when it harbors or when it gathers some more mutations, namely in P53, in androgen receptor, in APC, RB1, cyclin, CDK12 gene, when they gather more mutations, it connotes poor prognosis, and that prostate cancer, which is localized, becomes metastatic prostate cancer. And in addition, what is important is there are problems related to homologous recombination deficiency related genes, as well as Fanconi Fanconi anemia related mutation. Next is CDK12 mutation, and then MSI related abnormalities. So all these are part of metastatic prostate cancer. Coming to gene expression assays in localized prostate cancer, we all are familiar with Oncotype DX test in ER positive breast cancer. Similarly, there are gene expression assays in localized prostate cancer, and they are available to predict risk of distant metastasis and prostate cancer related mortality in very low risk and low risk disease. And in our center, we come across mostly advanced prostate cancer or metastatic prostate cancer. So in our center, we haven't been using gene expression assays, but wherever, whichever center which is attracting localized disease, very low risk disease, they may be interested in this. Here, there are multiple assays. But the problem is they are very exorbitant. And if you compare with established clinicopathologic prognostic parameters in the setting of active surveillance, the value remains to be determined whether they have any discriminatory value. And so let's have a look at one such assay, which is Decipher assay, 22 gene expression assay, where like Oncotype DX in breast cancer, lower Decipher score tells you that there is little or no benefit from addition of anti-androgen therapy to salvage radiotherapy, and higher Decipher scores, they tell you that there is benefits associated with anti-androgen therapy. And the test can also successfully predict 10-year metastasis risk. So this is about gene expression assays in localized prostate cancer. Coming to genetic testing in metastatic prostate cancer, I have already stated that TCGA has classified localized cancer into 7 molecular subtypes. If you apply that classification, only 68% of metastatic prostate cancers can be clustered into 7 subtypes. There are additional therapeutically actionable targets. I have already stated earlier when I showed you that cartoon that there is homologous recombination deficiency, microsatellite instability, and CDK12 deficiency, that is cyclin-dependent kinase 12 deficiency. These are the therapeutically actionable subtypes in addition to 7 molecular subtypes in metastatic prostate cancer. In addition, there can be mutations in androgen receptor P53, APC, RB1 gene, CDK12. They are significantly enriched in metastatic castration-resistant prostate cancer. Alteration in RB1, TP53, and androgen receptor genes, they indicate shorter responses to androgen receptor signaling inhibitors, and RB1 mutation indicates shorter overall survival. So this is about genetic testing in metastatic prostate cancer. Coming to HRD, my job is a little easier because tomorrow there is a separate talk on this particular topic, and that's the reason I'm not going to delve much on it. So HRR, that is homologous recombination repair, is a DNA repair pathway that acts on double strand DNA double strand breaks and interstrand crosslinks. Presence of HRD, that is deficiency of these repair genes, can make tumors more sensitive to interstrand crosslink inducing platinum-based therapies and PARP inhibitors. And PARP inhibitors work via synthetic lethality. And what they do is they accumulate DNA single-strand breaks. And these breaks cannot be repaired if the tumor has HRD, that is homologous recombination deficiency. The repair genes are lacking. And for pathologists in the audience, for what are the morphologic correlates for HR homologous recombination deficiency, the tumors which show this particular molecular events morphologically, we see them as intraduct carcinoma or cribriform pattern on a prostate biopsy. And additionally, HRD is also positive prognostic factor for both progression-free survival and overall survival. So this is a cartoon about HRD, and there are multiple genes involved, and there are various events, genetic, epigenetic events, and currently unknown events. And there are assays available based on next generation sequencing technology. So here is a long list of genes which are involved in prostate cancer, both localized and metastatic, and it starts with TEMPRESS or TEMPRESS to ETS fusion, and it ends with, and of course it's endless, but in this cartoon it is ending with BRCA2 and ATM, and that indicates homologous recombination deficiency, which is there in prostate cancer and which is amenable to therapy by PARP inhibitors. Coming to mechanisms of resistance, because you diagnose prostate cancer, androgen receptor blockade strategies are used, but the tumor escapes this and develops resistance, and that happens because constitutively active androgen receptor splice variant, and this particular splice variant can be estimated in circulating tumor cells or circulating cell-free DNA through liquid biopsy platforms, and this assay helps predict a poor response to second-generation AR antagonist. Coming to another feature in prostate cancer, which is lineage plasticity. And here the prostate cancer develops neuroendocrine features, and that happens because of P53, RP1, and PTN loss. And when you have this particular feature, it indicates it's a very sad story for the patient, because patient is destined to dismal median survival up to 12 months. So role of pathologist in selection of the tissue is 10% neutral buffer formalin, avoid frozen or tissues fixed in non-formalin, ensure adequate tissue, ensure highest grade and largest volume block of tissue, which is containing the highest grade and largest volume is given to the patient for further testing, and tumor is chosen which is treatment naive, neither radiated nor received any anti-hormonal treatment. So there are some practical key points that prostate cancer is heterogeneous, and the rest of the genes and events I already described. Let me go to bladder carcinoma. Here, traditionally, pathologist describes bladder carcinoma as low-grade, non-muscle invasive, and muscle invasive. So there is molecular classification, which is important because it predicts the response to the treatment, and it unravels the evolution of bladder cancer through different pathways. So there is papillary pathway, there is non-papillary pathway, and for papillary pathway, the characteristic alterations are fibroblast growth factor receptor 3, LOH at 9p, 9q, TERT mutations, whereas in non-papillary pathway, there is problems with DNA replication and repair genes, RB1, P53, P10 loss, ERCC2 alterations. However, two pathways at times or sometimes they do intersect. So if you take papillary pathway, there are three classes, class 1, class 2, and class 3. And for non-papillary pathway, there are 6 subtypes. So for non-muscle invasive molecular subtypes are class 1, class 2, class 3. Class 1 is luminal-like features. Class 2 is also luminal-like features, but it is on its high grade and it has elevated expression of late cycle regulators, whereas class 1 is good prognostic variant, and on histology also it shows low grade papillary carcinoma. Class 3 is basal like features, and Basically, it is muscle invasive type, but when muscle invasive high grade type is still has become and not invaded the muscle, and if it's still confined to the mucosa, non-muscle invasive, that is that class 3. So this table summarizes class 1, class 2, class 3 non-muscle invasive bladder tumors. So FGFR3 mutation, luminal class 2 is HER2 amplification, and class 3 again is basal type. And only class 1 is at high risk of recurrence, whereas other two is high risk of progression. Coming to muscle invasive bladder cancers, there is luminal papillary, luminal non-specified, luminal unstable, basal or squamous, trauma-rich, and neuroendocrine. So neuroendocrine is neuroendocrine, basal squamous is rich in EGFR mutations, luminal unstable is HER2 amplification, shows HER2 amplification, luminal non-specified shows PPARG mutation, that is peroxyzyme proliferation activator receptor gamma. And luminal papillary is FGFR3 mutation, and CDKN2A that encodes for P16, that is deletion. I have to hurry, and because I want to avoid that bell. So subtypes I have again mentioned here with corresponding treatment. Luminal papillary can be treated with FGFR3 inhibitor. These are the candidates for early cystectomy without chemotherapy. And basosquamous or basal or slash squamous, these are the tumors which will receive immune checkpoint inhibitor treatment and neoadjuvant chemotherapy. And neuronal tumors receive etoposide plus cisplatin based therapy. So molecular subtypes have shown differential responses to immune checkpoint inhibitors, with the luminal infiltrated and basal squamous subtypes having favorable response. In addition to that, PDL1 expression, tumor mutational burden, and presence of microsatellite instability, mismatch repair deficiency, they are all being evaluated as predictors of response to immunotherapy in bladder and upper urinary tract carcinoma. Coming to kidney tumors, the first part is clear cell carcinoma, conventional clear cell carcinoma with multiple molecular abnormalities and as part of hereditary syndromes. But the newest, the recently introduced classification has a separate category of molecularly defined renal carcinomas. Now here is the long list of hereditary renal carcinoma syndromes with von Hippel-Lindau gene, which is present on 3P. When that is lost, then hereditary papillary RCC, HLRCC. So there is a long list. Even tuberous sclerosis genes are associated with various syndromes. This is Cancer Genomic Atlas pan kidney cancer analysis, but I'll talk about conventional renal cell carcinoma. Here, VHL loss constitutes the earliest and fundamental driving event in the development of conventional renal cell carcinoma. And this is the list of molecularly defined RCCs, that is medullary carcinoma, TFEB altered RCC, ALK rearranged RCC, elongin C mutated RCC, USC RCC, TFE3 altered and succinate dehydrogenate deficient renal cell carcinoma, and HLRCC. So that's I think I covered all the three sites, and thank you very much for patient hearing.